In today's video, we will focus on endocrine pathology. In the previous video, we reviewed hormone action, regulation, and gland anatomy. Briefly, hormones bind to specific receptors, and most are regulated through negative feedback to maintain homeostasis. Understanding these basic principles helps us recognize how dysfunction develops. Now let us proceed to the pathology. What happens to the body when the thyroid gland produces too little or too much hormone? The thyroid gland regulates metabolism. Dysfunction leads to either hypothyroidism or hyperthyroidism, which have opposite metabolic effects. Hypothyroidism refers to low thyroid hormone levels, causing metabolic processes to slow down. The most common cause is Hashimoto's thyroiditis, an autoimmune disorder in which the immune system attacks the thyroid gland. It may also occur with iodine deficiency or after thyroid removal. Reduced T3 and T4 levels result in decreased metabolic activity. Patients commonly present with cold intolerance, weight gain, fatigue, and bradycardia. Other findings include constipation, delayed reflexes, and a puffy facial appearance. These features reflect a generalized slowing of body systems. Hyperthyroidism occurs when thyroid hormone levels are elevated, most commonly due to Graves' disease, another autoimmune condition. In this case, metabolism becomes excessively fast. These patients develop heat intolerance, weight loss despite normal intake, and tachycardia. They may appear anxious and tremulous, have frequent bowel movements, and demonstrate hyperreflexia. In Graves' disease, protrusion of the eyes, known as exophthalmos, is a characteristic finding. A useful way to distinguish these conditions clinically is by heart rate and energy level. Hypothyroidism is associated with slowing, while hyperthyroidism is associated with acceleration. Now let's move on to life-threatening conditions associated with hypothyroidism and hyperthyroidism. These represent the most severe forms of thyroid dysfunction and require immediate recognition. First is the myxedema coma, which is a critical form of hypothyroidism. Patients often present with a non-pitting edema, altered mental status, and hypothermia. Common triggers include infection, trauma, and cold exposure. In contrast, thyroid storm represents the extreme form of hyperthyroidism. It occurs when thyroid hormone levels become dangerously high, often after surgery, trauma, or infection. Key features include high fever, severe tachycardia above 140 beats per minute, agitation, and delirium. These conditions are medical emergencies, and exercise is contraindicated. If these signs appear during evaluation or treatment, therapy must be stopped, and the patient must be referred immediately for emergency medical care. The adrenal cortex controls salt, sugar, and sex hormones through 3 layers. The zona glomerulosa produces aldosterone. The zona fasciculata produces cortisol. The zona reticularis produces androgens. Impaired hormone regulation in the adrenal cortex leads to Cushing's syndrome and Addison's disease. Cushing's syndrome results from excess cortisol and is marked by a rounded face, fat accumulation over the upper back, and the central weight gain with thin extremities. Patients also develop purple abdominal striae, proximal muscle weakness, osteoporosis, and often hypertension. Because cortisol weakens bone and muscle, fracture risk is high and exercise tolerance is reduced. Addison's disease is a form of adrenal insufficiency caused by failure of the adrenal cortex. You're losing both cortisol and aldosterone. Patients typically present with weight loss, muscle wasting, fatigue, and low blood pressure. A hallmark sign is hyperpigmentation, which gives the skin a bronze tone and results from elevated ACTH, stimulating melanocytes. Darkening of the gums and reduced appetite are also common. When adrenal insufficiency is caused by pituitary failure, hyperpigmentation is not seen because ACTH levels are low. The antidiuretic hormone, or ADH, regulates water balance at the kidneys, and impaired regulation leads to abnormal fluid balance. Diabetes insipidus develops when ADH is low or when the kidneys do not respond to it. The result is large amounts of dilute urine. Patients present with polyuria, polydipsia, dehydration, and hypernatremia. In contrast, SIADH occurs when too much ADH is released, Excess water is retained, leading to low urine output and dilutional hyponatremia. Patients may develop headache and confusion from low sodium levels and fluid overload. These two conditions differ in how they affect body water levels. Diabetes insipidus causes dehydration, whereas SIADH causes fluid overload. Growth hormone influences bone and soft tissue growth, and timing of excess growth hormone determines the clinical presentation. The two main disorders are gigantism and acromegaly. Gigantism occurs when there's excess growth hormone before the epiphyseal plate closes. This leads to extreme height with body proportions remaining normal, while acromegaly happens after epiphyseal closure. Now, you can't grow taller, but bones thicken disproportionately. Height no longer increases, but bones thicken unevenly. Common features include enlarged hands, feet, and jaw due to bone overgrowth. Enlargement of the heart is also common. Both conditions are associated with joint degeneration, pain, and reduced exercise tolerance due to skeletal and cardiac changes. Careful progression is needed because of joint stress and cardiac involvement. Now that we have covered growth hormone disorders of the pituitary gland, we will move on to disorders of the pancreas that affect blood glucose regulation. The pancreatic islets contain beta cells that produce insulin and alpha cells that produce glucagon. These hormones work together to regulate blood glucose. When insulin production or insulin action is disrupted, diabetes mellitus develops. In type 1 diabetes, beta cells are destroyed by an autoimmune process, resulting in little to no insulin production. These patients require insulin therapy and are at risk for diabetic ketoacidosis because fat is used for energy, leading to ketone production. Type 2 diabetes develops from insulin resistance with a gradual decline in insulin production. Body cells do not respond properly to insulin, and the pancreas cannot compensate adequately. This condition is closely linked to obesity and low physical activity. Treatment begins with lifestyle modifications and oral medications, with insulin added if needed. The main acute risk is hyperosmolar hyperglycemic state. Diabetic emergencies happen when blood glucose drops too low or rises too high. An example of this is hypoglycemia and diabetic ketoacidosis. Hypoglycemia occurs when blood glucose falls below 70 milligrams per deciliter. Signs include shakiness, sweating, confusion, fast heart rate, and dizziness. Treat immediately with carbohydrates. If unsure whether a patient is hypo or hyperglycemic, treat for hypoglycemia first. Diabetic ketoacidosis occurs mainly in type 1 diabetes and involves severe hyperglycemia with ketone production. Key signs include fruity breath, deep, rapid breathing, and nausea or vomiting. This condition requires urgent medical care. Quick review. If confusion, pallor, or fainting occurs during activity, suspect hypoglycemia. DKA develops more slowly but still requires emergency referral. Parathyroid hormone regulates calcium levels in the body by acting on the bones and kidneys to increase blood calcium. When this system is disrupted, parathyroid disorders develop that alter calcium balance. Hyperparathyroidism causes high calcium. Here's a mnemonic to help you remember the signs: stones, bones, groans, and psychiatric overtones. Patients develop kidney stones from the excess calcium. They have bone pain and fractures from osteoporosis because PTH is pulling calcium out of bones. Abdominal groans refers to GI discomfort, and psychiatric overtones means mood and cognitive changes. Hypoparathyroidism causes low calcium, leading to neuromuscular irritability. Patients develop tetany, muscle cramps, and paresthesias. Two specific signs are Kvostek's sign, where tapping the facial nerve causes facial twitching, and Trousseau's sign, where inflating a blood pressure cuff causes carpal spasm. Now we're looking at specific endocrine tumors you need to recognize. Pheochromocytoma is a tumor of the adrenal medulla that releases catecholamines. It classically presents with headache, sweating, and severe hypertension. A key concern is sudden spikes in blood pressure during activity, which require stopping and urgent referral. Prolactinoma is a pituitary tumor that produces excess prolactin. Common features include visual field loss from optic chiasm compression, amenorrhea, and galactorrhea. MEN syndromes are inherited disorders that cause tumors in multiple endocrine glands. MEN type 1 involves the parathyroid, pancreas, and pituitary. MEN type 2 affects the thyroid medullary cells, parathyroid, and adrenal glands, with pheochromocytoma as a major feature. Now that we have covered metabolic disorders, we can look at how these conditions affect exercise and rehabilitation. It can alter the metabolism, heart rate, and stress tolerance, which all influence how patients respond to activity. Thyroid disorders strongly affect exercise capacity. In hyperthyroidism, resting metabolic rate and heart rate are elevated, increasing the risk of tachycardia and arrhythmias during activity. Exercise should be approached with caution. In hypothyroidism, metabolism is reduced, leading to fatigue and bradycardia, so progression should be slow and gradual. In diabetes, timing of exercise is important because physical activity lowers blood glucose. Exercise should be planned when glucose levels are stable and not during peak insulin action to reduce the risk of hypoglycemia. Typically, it's recommended that exercises are performed in the mornings, and insulin injections be placed into non-active areas, such as the abdomen, because insulin is absorbed more quickly in muscles that are actively working. Know this: avoid exercises 2 to 4 hours post-insulin injection, do not exercise before bed, and monitor blood glucose levels before, during, and after exercise. Additionally, make sure to factor in temperature. Very hot or very cold conditions add stress to the body and can affect glucose control, so these extremes should be avoided during exercise. Lastly, it is recommended that you exercise 150 minutes per week, progressing to 300 minutes per week. Perform moderate intensity exercises 3 to 5 days per week to improve health in diabetic patients. Adrenal insufficiency, such as Addison's disease, reduces tolerance to physical stress and often causes low blood pressure. These patients require conservative progression and close monitoring during activity. As for muscle capacity and performance, endocrine disorders produce distinct neuromuscular patterns that you should be aware of, such as proximal muscle weakness, tetany, peripheral neuropathy, and arthralgia. Proximal muscle weakness is common in Cushing syndrome and thyroid disorders. When weakness affects both sides and does not match a nerve pattern, an endocrine cause should be considered. Tetany and cramping indicate hypocalcemia from hypoparathyroidism. The muscles are hyperexcitable from low calcium. Peripheral neuropathy is a common complication of diabetes mellitus. Loss of protective sensation increases the risk of injury because patients may not feel developing wounds. Patient education on daily foot inspection and proper footwear is essential to prevent skin breakdown and infection. Arthralgia and myalgia are common in acromegaly and hypothyroidism. Joint pain without clear mechanical cause should raise your suspicion. Lastly, these disorders also affect tissue healing and bone density, which can influence rehabilitation outcomes and increase fracture risk. Let's take a look at how they can cause osteoporosis, affect wound healing, and cause ligamentous laxity. Several conditions raise the risk of osteoporosis. Hyperthyroidism increases bone turnover. Cushing's syndrome causes bone loss due to excess cortisol. Hyperparathyroidism pulls calcium from bone through active resorption. Menopause also increases fracture risk because estrogen's protective effect on bone is lost. Wound healing is delayed in both Cushing's syndrome and diabetes. Elevated cortisol interferes with normal tissue repair, while uncontrolled blood glucose increases infection risk by impairing immune function and promoting bacterial growth. Ligament laxity increases during pregnancy due to the hormone relaxin. This mainly affects the sacroiliac joint and pubic symphysis, leading to greater joint instability and the need for modified treatment strategies. That concludes our review of the major endocrine disorders. At this point, you should understand which hormones are involved, whether their levels are too high or too low, and how these changes affect metabolism, exercise tolerance, and tissue healing. For more videos like this, visit typicalpt.com. The full course covers every topic on the NPTE to help you pass the first time. Thanks for watching, and we'll see you in the next one.